I'm Sherif Awad, Consultant Bariatric Surgeon, and in this video, I will take patients through what bariatric surgery is, preparation for surgery, how to choose an operation, the different operations we do, recovery after surgery, and what life will be like afterwards. We'll start off with BMI, body mass index. This in the main is calculated by taking your weight in kilograms and dividing it by the height squared. And BMI is a measure of how much excess weight each patient carries. A normal BMI is up to 25. A BMI between 25 to 30 is classed as overweight. 30 to 35 is stage 1 obesity. 35 to 40 is stage 2 obesity. And anything over BMI 40 is classed as stage 3 severe obesity, what we used to call morbid obesity in the past. Now, the reason BMI is important is because we use it to determine the eligibility for surgery. And in the main, us surgeons, we use BMI 35 as the cutoff, but also patients who have obesity-related comorbidities at a BMI of 30, such as diabetes, high blood pressure, etc., they may also be eligible for surgery. Now, why do we offer bariatric and metabolic surgery? The vast majority of patients who come to see us will have tried dieting for numerous years, and they may have tried various diets, Weight Watchers, Slimming World, Cambridge, Dukan, Keto, etc. The vast majority of patients are able to lose weight, but the problem is in maintaining the weight for the long term. And unfortunately, the vast majority of diets fail in the long term, with patients regaining most of the weight that they've lost. In this slide, the investigators studied almost 175,000 patients and followed them for over 9 years, and the chances of patients losing weight and getting down to a normal weight with diet and exercise, if they were BMI 40 to 45 as a woman, the chance of that happening is 1 in 700. For a man, the chance of that happening is 1 in 1,300. And so dieting and exercise are actually really hard way to maintain the weight loss in the long term. More importantly, obesity has been classified as a chronic disease. And when you hit BMI 40 to 50, this in itself reduces your life expectancy by between 8 to 10 years. It increases the risk of you developing diabetes massively. For each BMI unit, there is an increase in the risk of diabetes. There's an increase in the risk of heart attacks and strokes. And importantly, obesity is one of the leading causes of cancer. And around 10% of cancer deaths in non-smokers are related to obesity, and obesity contributes to the development of around 13 different cancers that commonly occur in patients all over the world. And these may include breast, ovary, stomach, esophageal, pancreatic, kidney, and liver, so the common cancers. Obesity is also responsible for developing a number of other conditions, such as sleep apnea, heart disease and heart attacks, strokes, arthritis, polycystic ovaries, and reduced fertility in women of childbearing age. So it has a massive impact on a patient's health and future prospects. For patients who have made the decision to proceed with a surgical operation, you will have a consultation with a consultant surgeon such as myself, followed by a multidisciplinary team assessment, which includes a dietitian review and a review by a psychologist or a psychotherapist. And the team will determine how patients eat, what common pitfalls they fall into, and also they will advise some changes to their dietary and lifestyle habits, such as establishing a regular meal pattern, reducing snacking grazing, reducing portion size. And ideally, patients should not gain weight beyond their initial consultation with the surgeon, because this is a sign that they've implemented the changes that we require them to do before the surgery, and these changes will be very important to implement and continue long-term after the surgical operation. One of the habits that we all get into is eating and drinking at the same time, and after your operation, you will no longer be able to eat and drink at the same time. What you will be asked to do is to separate eating and drinking by around 20 minutes. Fizzy drinks should be stopped, and alcohol intake should be reduced to allow the liver to recover and to reduce potential risks from the surgery. I am one of the surgeons who do not operate on smokers because smoking in itself can increase the risks of developing serious complications after surgery. For patients who vape nicotine-containing products, I ask my patients to stop nicotine vaping for 1 week before and 6 weeks after surgery, because again, nicotine can affect the wound healing and increase the risks after surgery. Ideally, patients should implement regular activity and exercise into their everyday life, and we advise to undertake at least 30 minutes a day of moderate activity, which is any activity that increases the heart rate and gets you out of breath, and you should aim to implement this into your everyday life. The liver shrinking diet is incredibly important before your weight loss operation, because in patients who have obesity, most patients will have big fatty livers which lie over the stomach. And the first part of any operation we do involves lifting the liver up to allow the surgeon to get to the stomach and do the surgery that they need to do. And so the LRD, the liver reducing diet, comprises of 800 calories a day of specified foods that are low in carbohydrates and low in fat, and they are very effective to help to shrink the liver. I will ask most of my patients to do a liver shrinking diet for a period of 2 to 4 weeks before surgery, depending on the BMI. It's important to take regular laxatives when you're on the LRD and to drink plenty of fluids to avoid you becoming constipated before the surgery. We don't want you coming in for your operation experiencing constipation. Finally, it's very important that you read all of the information provided by me, surgeon, and also by the multidisciplinary team, and you fulfill and complete the instructions that we give you before the surgery, because this will give you the best outcome before operation. All the procedures that are done are completed using laparoscopic surgery, so keyhole surgery, which involves making a few small scars under anaesthetic. The commonest operation performed is the sleeve gastrectomy. The next commonest is the Roux-en-Y gastric bypass, and another operation which has recently been implemented over the last 10 years is the one anastomosis, otherwise known as the mini gastric bypass. So how do you choose an operation? The first thing I'll say to patients is I would advise you to keep an open mind, and your surgeon, after doing the consultation with you, will guide you as to what the most appropriate operation will be. Because there are certain conditions that may be present which make it inadvisable to choose a particular operation. As an example, the sleeve, we tend to avoid the sleeve in patients who have severe acid heartburn and reflux, patients who are already known to have Barrett's esophagus, which is a condition that affects the lining of the lower food pipe, patients who are known to have esophageal dysmotility, where the food pipe doesn't work properly, and patients who are known to have a hiatus hernia over 3 centimeters. In terms of the gastric bypasses, these are best avoided in patients who are smokers, because smokers can get severe ulcers in the future if they have a bypass. Certain medications that are taken regularly, such as aspirin, ibuprofen, naproxen, diclofenac, other nonsteroidals, these can also cause ulceration in the long term. Patients on regular daily steroids may also develop ulcers, and other important medications such as epilepsy and certain antidepressant medication may be affected in terms of medication absorption after the bypass. There are also other bowel disorders such as Crohn's disease, ulcerative colitis, celiac disease, and patients with severe irritable bowel syndrome where it would not be advisable to have a gastric bypass. Patients who have chronic pain and are on numerous medications are best to avoid the gastric bypass. Patients who have had major open abdominal surgery may have extensive adhesions inside their tummy, and therefore the small bowel loops may be matted together in adhesions, and this makes the bypass very, very difficult. There is a small group of patients who have functional GI disorders where they have a condition that affects the bowel, but the medics are not certain what that condition is. They also should avoid the gastric bypass. And finally, higher risk patients, such as those with kidney failure or liver failure, who need to have an organ transplant, they should also avoid the gastric bypass, as in the main, this is a higher complexity operation than the sleeve, for example. And the bypass should be used cautiously in patients who have type 1 diabetes because of the effects on blood sugar after eating. So what do we do when we perform these surgeries? We'll start off with the sleeve gastrectomy. This is the commonest operation which is performed under general anesthetic, 5 small incisions. And what we do is, after lifting the liver up, we go in and we staple the stomach and remove the outer 3/4 of the stomach and take it out of the body, including the upper part of the stomach, the fundus, which produces the ghrelin hunger hormones. So the effect of the surgery is to form a narrow stomach tube, which is the thickness roughly of my thumb and the shape of a small banana. The sleeve works by restricting the amount of food that can be eaten, by reducing hunger between meals, because the part of the stomach which produces the hunger hormones has been removed, and also by speeding up the emptying of the stomach, thereby releasing really good hormones which affect the appetite. The next operation is the 1 anastomosis gastric bypass, again performed under general anesthetic, 5 small incisions. And here what we do is we create a long pouch along the inner side of the stomach, again the thickness of my thumb. The original stomach stays in place. We take a loop of intestine, join it onto the bottom of the pouch, and so that's called the anastomosis, and essentially that's the end of the operation. The effect of the surgery is that patients, when they eat, the food will pass into the pouch and then it will be diverted to the lower parts of the intestine, missing the upper stomach and upper intestine. The enzymes which are produced by the remnant stomach and the upper small intestine, they go down, mix with the food lower down, and help the food to be absorbed. As a result of food being delivered to the lower parts of the bowel, this results in the intestines producing really good hormones, which reduce the hunger and increase fullness after eating. The 1 anastomosis gastric bypass, or the mini bypass, also works by restricting the amount of food that can be eaten and by reducing the surface area of the intestines that's available for absorbing the calories and energy from the food. So there's an element of malabsorption. Finally, the Roux-en-Y gastric bypass. This is the longest established operation. Again, keyhole, 5 small incisions. And what we do is we divide the upper stomach to create a little pouch the size of my thumb. We divide the intestine lower down, take a loop of intestine, join it onto the pouch, and then we do a second join between 2 parts of the intestine lower down. So the effect of the surgery, again, is to restrict the amount of food that can be eaten. Food will pass through the pouch and get diverted to the lower parts of the bowel, again mixing with the enzymes and digestive juices to be absorbed, and as a result of food being delivered to the lower parts of the bowel, really good hormones such as GLP-1 and PYY are produced, and these hormones will reduce hunger. In terms of recovery after surgery, I use an enhanced recovery after surgery protocol to try to optimize recovery for patients. And so my patients will be expected to be up and walking within a couple of hours of surgery. I will ask them to walk hourly until midnight, on the hour every hour. You will be doing incentive spirometry breathing exercises, and these help to open the bases of the lungs after surgery, and they work to reduce the effects of the anesthetic on the lung. They reduce chest infections, and also an added benefit is that these exercises will help to reduce the gas pain and trapped wind pain that can occur after keyhole surgery. After the operation, patients will be allowed to drink small sips of water only until the following day. The vast majority of my patients will go home on the day after surgery. They'll start the liquid diet, which they will be on for 2 weeks. Patients are allowed to shower on day 3 once the wounds are healed. You can drive on day 10 when you're safe doing an emergency stop. The vast majority of patients will be able to return to work 10 to 14 days after surgery, and we can issue sick notes if they are required. Most patients are able to get back to their normal daily activities within a couple of days of the operation. In terms of exercise, the gym, swimming, etc., this can be commenced approximately 6 weeks after surgery, provided all the wounds have healed. In terms of diet after surgery, patients will be allowed a liquid-only diet for the first 2 weeks after the operation, followed by a 2-week period on a puree-only diet, followed by a 2-week period of soft, easy-to-chew foods, and finally at 6 weeks, patients can resume eating normal textured foods. I advise all my patients to take daily laxatives, for example, senna, every day for the first month after operation, because constipation can occur really commonly, and it is the commonest encountered problem after weight loss surgery. And taking laxatives daily as well as maintaining adequate fluid intake will reduce the risk of severe constipation after weight loss surgery. In terms of the outcomes of the surgical procedures that we do, I'll start off by saying that all 3 operations are safe. they're all effective, and the risks of something going wrong and serious complications are all incredibly low. With the sleeve, the operation will often take 45 minutes to do. Patients will be allowed home the following day. The overall risk of dying is incredibly low. It's in the order of 1 in every 1,500 patients. The overall 30-day complication rate again is very low, in the order of 1 in every 100 patients. And the long-term complication rate is similarly low. It's around 1 in every 20 patients. On average, patients after the sleeve in the first 9 to 12 months of surgery can expect to lose between 25 to 30% of their total body weight. With the one anastomosis gastric bypass, the operation will take around an hour and a quarter to do. Again, patients will be in hospital overnight and home the following day. The risk of death after the operation in the event of a complication is incredibly low. It's around 1 in 500 patients. The 30-day risk of a complication happening is around 1 in every 50 patients, and the long-term complication rate is roughly around 1 in every 7 patients. The total weight loss expected with the one anastomosis gastric bypass is 30% in the first 9 to 12 months. Finally, with the Roux-en-Y gastric bypass, this operation takes around an hour and a half to do because in essence it's the most complex of the 3 operations to do. Patients again will be sent home the following day. The risks of death in the event of a complication after surgery is in the order of 1 in 300 patients. The risk of a complication occurring in the first 30 days, which may require a reoperation, is in the order of 1 in every 30 to 1 in every 50 patients. The risk of a long-term complication or a problem that needs addressing is around 1 in every 5 patients. And in terms of weight loss, following the Roux-en-Y bypass, patients can expect to lose between 30 to 35% of their total body weight in the first 9 to 12 months of surgery. In order to put these figures into context, I've added also some figures for gallbladder surgery, which is very commonly done to remove gallstones, for example, and you can see that the risk of death after a gallbladder operation is in the order of 1 in 900. So hopefully this will guide you as to the respective risks of weight loss surgery compared to a very commonly performed operation such as a gallbladder operation. So after the surgery, what are the benefits of a weight loss operation? The first thing to say is this will make patients live longer in the long term. And so the 10 years of reduction in life expectancy, which occurs as a result of obesity, this is reversed. And studies have shown patients who have a weight loss operation, they live longer than those with obesity who have not had weight loss surgery. One of the key reasons why we offer weight loss surgery is the improvement in obesity-related medical conditions such as type 2 diabetes, high blood pressure, risks of heart attacks and strokes. And for example, if you have developed diabetes in the last 10 years and you have a weight loss operation and you do well after your weight loss surgery, there is an 80% chance you will be cured from your diabetes. Similarly, with patients who have high cholesterol, high blood pressure, and conditions such as sleep apnea, there's around a 70 to 80% chance of a cure from these respective conditions. The overall risk of developing cancer is reduced after weight loss surgery. Patients with reduced fertility due to conditions such as polycystic ovaries may find that their fertility improves and they're able to fall pregnant either naturally or because they've lost weight, they can go on to have IVF and other means of assisted conception to help them to fall pregnant. Finally, patients with arthritis will often experience reduced pain, improved mobility, and improved exercise capacity. The vast majority of patients will have a great improvement in their quality of life, confidence, and self-esteem. The biggest feedback I get from patients when I follow them up after surgery is their regret that they didn't have the surgery sooner. And a lot of patients will feel very liberated in terms of their eating after the operation because they don't need to think about which foods to have, and they're able to eat whichever foods, but just in smaller quantities. In terms of the long term and life with a weight loss operation, you will need to eat 3 to 5 small meals a day and plan your meals so that you ensure that you get at least 60 grams of protein a day. This avoids hair loss, which can occur after weight loss operations. So the hair loss in itself isn't a side effect of the operation, but the commonest reason is due to patients not meeting their protein requirements. And so the 60 grams a day of protein is the key target that we ask patients to track. And really, we want patients aiming for between 80 to 100 grams of protein a day, because the higher the protein that you eat after surgery, the more weight you lose over and above what the weight loss operation gives you. Patients should also drink around 1.5 litres of fluids in total a day, because this reduces the side effects like constipation. You should aim to have your bowels open every 2 to 3 days after surgery. And again, you need to keep an eye on how much fibre you're eating and consider using occasional laxatives to ensure your bowels are working. Constipation after surgery can occur, but unfortunately can result in nausea, reduced appetite, and reduced ability to finish the food on the plate. I advise all my patients to undertake at least 30 minutes a day of moderate activity, which is classed as any activity that increases the heart rate and gets you slightly out of breath. And exercise in the first year after surgery is absolutely key, because this will ensure that you lose the weight that you've set out to lose, but then more importantly, it will reduce the risk of weight regain in the future. Please take your daily multivitamins, and these are often recommended lifelong after weight loss surgery. With all 3 operations, patients will be advised to have their bloods checked annually to ensure they've not developed any micronutrient deficiencies. Finally, it's vitally important to keep up with your follow-up appointments, especially with the surgeon and other members of the multidisciplinary team, such as the dietitian and psychotherapist, and you will do best if you keep in touch with the team and get regular advice from them. So in terms of post-operatively, potentially the things that can go wrong, and I will start off by saying that the risk of complications happening is very low, but in certain patients, they can go on to develop complications after surgery. So starting off with the sleeve, the risk of bleeding after surgery is very, very low, and my own personal risk is around 1 in every 500 patients. The risk of a leak is similarly low, in the order of 1 in 1,000 patients, and if patients develop a leak, this may occur in the first 4 weeks after surgery. After this, the sleeve is fully healed, the risk of bleeding and leaks disappears completely. In a small number of patients, around 1 in 10, the sleeve may result in them developing new symptoms of acid heartburn reflux, or existing symptoms of reflux may get worse, and this should be acknowledged before the operation. In very, very rare circumstances, there might occur a little narrowing or a twist in the sleeve, which leads to difficulties in eating after the operation. Symptoms such as vomiting, nausea may result in poor nutrition, and very rarely patients may need to have nutritional supplements and may need to have further corrective surgery in the future. With any weight loss operation, there is a risk of nutritional deficiencies, particularly if patients do not keep up with taking their daily multivitamins, and very rarely after the sleeve, other side effects such as dumping syndrome and low blood sugar hypoglycemia attacks after eating may also occur. With the mini bypass and the Roux-en-Y gastric bypass, there are similar risks to the sleeve, but the rates are a little bit different. The rate of bleeding is in the order of 1 in every 50 to 1 in every 100 patients. The risk of a leakage after the bypass or a mini bypass is in the order of 1 in every 250 patients. Because there are joins, artificial joins in the bypass, there are risks of ulceration and stricturing, and these are increased if patients resume smoking after surgery. One important complication that patients who are considering the bypass need to be aware of is there is a 1 in 100 risk every year of developing an internal hernia, which occurs because of a twist in the small bowel that leads to a bowel blockage, and this is an emergency condition which needs urgent and immediate surgery to put it right. Around 1 in 5 patients after the bypasses may develop food intolerance or pain after eating, which may affect which foods they're able to eat after the operation. And dumping syndrome, low blood sugar attacks, and nutritional deficiencies may occur more commonly after the bypasses than the sleeve because of the anatomical changes that are involved in making the bypass. Finally, with the mini gastric bypass, this comes with its own set of additional side effects that patients need to be aware of. The most important ones is developing bile reflux, which in a small number of patients may be so severe as to reduce quality of life and require corrective surgery in the form of converting to a Roux-en-Y gastric bypass. Patients with the one anastomosis gastric bypass or mini bypass, they may also develop severe diarrhea to the extent that they may have to go to the toilet 10 to 12 times a day, and this may again affect their quality of life. And finally, the studies have reported that patients are more likely to develop malnutrition and nutritional deficiencies with the one anastomosis gastric bypass. And with any weight loss operation, this requires a lifelong commitment to eating the right foods, to doing regular exercise. Otherwise, there is a risk of weight regain in the future, and this can happen after any weight loss operation. And the importance of the aftercare for patients is to ensure that patients are aware of the lifestyle habits and the dietary habits that they need to maintain in the long term in order to get the best results from their operation. Finally, in patients who are of very high BMI initially, there is a chance that they may go on to develop excess loose skin after they lose weight, because all the fat which is stored under the skin melts away and patients may end up with loose skin folds. So this is again something that patients should be prepared for. My final slide covers post-op supplements which are required to be taken. And so after the sleeve, you'll be required to take an acid heartburn tablet for the first 6 months during the healing, and then most patients can wean the acid heartburn tablets down and come off them. You need to stay on a daily multivitamin for life, a vitamin D supplement for life, because most patients with obesity have a vitamin D deficiency. Iron supplements, particularly in female patients who have regular periods, will reduce the risk of anemia, but also important for men after surgery. And most patients will need a 3-monthly vitamin B12 injection for life. The alternative is to have oral high-strength tablets or a vitamin B12 nasal spray. And again, annually, patients will be required to have bloods after surgery every year going forward to ensure that any micronutrient deficiencies are picked up and addressed. After the one anastomosis gastric bypass, I advise all my patients to remain on an acid-suppressing tablet for life. After the Roux-en-Y gastric bypass, this can be taken for 6 months and then stopped. And again, after the bypasses, you'll be required to take a daily multivitamin for life, calcium vitamin D supplement for life, iron tablet daily for life, and a 3-monthly B12 injection. And the most important message for patients considering a gastric bypass is you must avoid taking regular non-steroidal medications such as Brufen, naproxen, diclofenac, because if you do, you run the risk of developing a severe ulcer. And similarly, I advise all my gastric bypass patients to not smoke in future, because this is a very, very high risk factor for inducing severe ulceration, which causes significant problems after the gastric bypass. And similarly, after the bypasses, you will be required to have annual bloods to rule out micronutrient deficiencies. Thank you.